that we are featuring in this conference. So yeah, so Dr. Haynes, if you don't mind, just you can go ahead and set up and start to share your screen. It's just to make sure all of that is working. Okay. Yep, we see your screen. Yep, okay. All right, and it is advancing appropriately. Just want to make sure everything is advancing on your end. All right, excellent, excellent. Okay, we may take about 1 more minute or so to let folks finish the evaluation and put their name in the chat. Okay. As people are putting their name in the chat and completing the evaluation, again, during this portion, this is our Arkansas's Got Talent portion of our conference. So again, we had Dr. Rutherford, and now we have Dr. Tiffany Haynes, who is going to talk with us about promoting emotional wellness in rural African-American churches, lessons learned from Rejoice. So she actually did this presentation. My understanding, there's some version of this presentation for UAMS Department of Psychiatry Green Rounds, and it was so excellent. We asked her to come and present it for our group here, just to feature the talent that we have here in Arkansas and all of what Dr. Haynes is doing in the community. So just to say a little bit about Dr. Haynes as we're transitioning, she's a clinical psychologist with expertise in mental health services research, intervention development, and community-based participatory research. Dr. Haynes completed a master's degree and doctorate in psychology at the University of Michigan in Ann Arbor. She later completed a postdoc fellowship in advanced psychology at Central Arkansas Veterans Healthcare System in Little Rock. She is currently a professor in the Department of Health, Behavior, and Health Education at the University of Arkansas for Medical Sciences and the College of Public Health. And she has dedicated her career to improving access to and use of mental health services within underserved communities, with a specific emphasis on building partnerships with faith-based communities. She's done great work with that. She received a KL2 Mentored Career Development Award to examine the relationship between religious beliefs and attitudes about mental health services. So she has continued to do wonderful research and is the co-founder of the Arkansas Faith Network, which is a coalition of places of worship, healthcare organizations, health researchers that partner together to reduce health disparities. So we just appreciate all the work that she's doing. She's doing more and more speaking engagements and has provided mental health education talks at national conferences, and also recently gave a TEDx talk in 2020 entitled "It's Okay Not to Be Okay." So we're just glad she's here to share her expertise and all of the work that she has been doing across the state of Arkansas. So I'm just going to go ahead. I'll say, if I say go blue, okay, Eric says go blue. Yeah, rock star. That's it. Okay, so I'm going to turn it over to you, Dr. Haynes.
Good afternoon, everyone. Thank you so much for the opportunity to close out the conference this year. I just actually looked through my window right before I jumped on and turned on my camera, and I realized it's an absolutely beautiful fall day, and I can see people getting ready to tailgate for the game tomorrow. So I just want to let you know that I do not take it for granted that you chose to hang in here with me on a Friday afternoon to hear more about this conversation. So thank you for staying with us. And because this is the end of the conference, you've got a lot of great information. We're going to switch gears a little bit because, as Dr. Holmes read in my bio, I am more of a researcher hat on today. And so I want to make sure that we're having good conversation. So I encourage you to please use your chat, ask questions, give comments, use your reactions, tell me what we need to do. Oh, I have a lot of football fans in the chat. I can see it. And I want to know, I will be at the game tomorrow for everyone. I'm going to be a Hogs and a Lions fan. So I am going to unite all of the fans here. And I also will be a Wolverine fan as well. I have it all covered. Don't worry about it. But please use your chat, use your reactions. Please engage in conversation and be interactive with what we're going to talk about. Because we're going to be talking about lessons learned from a project that we have to promote emotional wellness in rural African-American churches. You're going to hear me talking, you'll hear my voice and see my slides, but I don't want you to think that I am the only one that has been a part of this work. And so I want to start off by acknowledging those people who came before me, those people who started this work here in Arkansas. And I actually saw that one of our trailblazers, Dr. Teresa Kramer, is in the chat today. So we want to make sure that we acknowledge her work in talking about mental health in faith-based communities. And one of the first projects that I was a part of here was led by Dr. Gris Sullivan, and it started in the VA, where we talked about how do we connect with faith leaders and clergy and to encourage mental health service use within veteran populations. So this was one of the first projects in the VA that kind of focused on this work. And it gave us a lot of opportunity to talk about how do we partner with faith communities? How do we talk about mental health in faith communities? How do we even talk about veteran affairs in faith communities? And so we learned that a lot of times we say, you know, you have to go to the pastor, but the person who does the work is the people who are in the congregation. So the ministry leaders and the first ladies, and those are the people that you're going to be really working closely with, but you got to get the endorsement from the pastor. And we learned that very quickly. I like to say that some of our clergy and pastors are like the LeBron. When they say it's good, then it's good to go. So we learned from this project just kind of the mechanics of how to partner. And so I want to acknowledge all of those who worked on this project with us. And then we moved from that VA to really focusing on rural African American needs. And again, Dr. Sullivan was a part of this project. And we moved on with working with Tri-County Rural Health. And we had a host of other individuals who we went out into community and we did focus groups. And we did town hall discussions about what do you think of when you hear mental health? What does this look like? And one of the main things that we learned from that study was about the language that we use. So we had one of our CAB members talk to us and say, when you say mental health, you're talking about crazy people. And I'm not crazy and I don't know how to help you help crazy people. So if you're going to use mental health, nobody's going to talk to you. And this is when we started making the switch to emotional wellness so that we would get a language that would immediately not make people say, I'm not a part of this conversation. But we changed that language so that they would feel a part of the conversation so we could start addressing needs. And then we moved on from that study to our Rejoice project. And so this is some pictures of our Rejoice team. We have a huge team that works together on how to develop our intervention, but also learning how to implement it. And so I don't want to start the day without acknowledging them and letting you know that we have a great group of people who are working on this work. We also want to acknowledge our funders, the National Institute of Health and Minority Health and Health Disparities. So let's get into the actual nitty-gritty of what I'm going to be talking about. I'm going to give you a little bit of background about how we came up with Rejoice, and then talk to you about our project. And today I won't be focusing on results as much as lessons learned. And so I hope that in those lessons learned, there's some things that we could take out, not just for research or partnering with faith communities, but also how can we partner with faith communities in our clinical work as well. So I encourage you again to be thinking about that. Please drop them in the chat as you have questions and comments. So how did we get here? We had a pastor in the Arkansas Delta come to us and say, I'm worried about our minds, especially our young people. You didn't hear about depression or suicide. That was never something you heard about with our people. Now I've had to sit with several families of young Blacks who have taken their own lives. I have people who are depressed in my congregation. And not too long after he told us this story, he told us another story of where he had a young teenager that was had gotten into trouble, and he spent all night praying with him. And when he left him that morning, he went home, and a few hours later, that young man actually attempted suicide. And that stuck with him because he said, I prayed, I did everything I knew how to do, but I didn't know how to get to that other side of getting him to the help that he needed. And so he really was the catalyst for this work. And how do we talk about mental health? And how do we make sure that we're talking about mental health in ways where people are able to better access services when needed? So that happened right before we did our PCORI study of addressing the emotional wellness needs. And we did our focus groups with faith leaders, college students, and mental health providers. And from that work, again, we found out kind of how people think about mental health. What are they thinking when they hear the word? And they talked to us about stigma and how in rural communities, it's very difficult to be able to go to the mental health clinic there because everyone knows your car. Everyone knows that you're sitting there. And so when you go there, it's not a secret. So they were talking about how I would go get help if it wasn't something where everybody had to know about it. They also talked about like just the the quality of the care that they thought they were receiving. They said, we don't have many people here that are providing care. And so how do we get it? How do we know that they're telling us what they should be telling us? We don't know about that. So they had concerns about those types of issues. And so from that, as a part of the Faith Academic Initiative to Transform Health in the Delta, so it's called Faith in the Delta, we talked more about how can we learn more about this. And so we did needs assessments in 40 churches across the Delta. We went to them and we said, hey, you tell us kind of what it is that you think we should be focusing on. And not just mental health, we had all the physical health conditions and everything. And what we noticed was that up to 30% of participants indicated some significant depressive symptoms. We gave them a PHQ-2 and they were in that clinical significant range. And so when we went back to talk to our CAB, our Community Advisory Board, about what we found, our CAB really targeted that depressive symptoms. And they said, you know what? This is something we need to talk more about. I'm seeing more hopelessness in our church. Every day in our congregations, people are, not as optimistic, not as hopeful as they used to be. And I think that's kind of a sense of our environment. And so how do we help them? What do we do with that? And so then we went back to our faith task force and we said, okay, if we do this, what is the next step? And our faith task force said, hey, we need to figure out how to get help here. There may be help in Little Rock, there may be help in Jonesboro, in Memphis, but what about here in the Arkansas Delta, in these rural areas? How do we do this? So what are our next steps from that? And we decided that if that's the case, we need to think about disparities in mental health care. So we have to think about the stressors that people are experiencing, specifically in rural African-American communities. So we talked about racism, discrimination, and poverty. Many of you know that the rural areas in Arkansas tend to be the areas with the highest level of poverty, highest levels of unemployment, and lowest levels of educational attainment. So those are the environmental stressors that are going on that can impact mental health. And then when we talk about getting help for those mental health issues, there's some barriers to care. And so we talked about the availability of services. Remember I said earlier that some of our participants talked about, we don't have services here in our area. We don't have a way to get that. They talked about transportation. So if you live in Phillips County, where a lot of our Faith Task Force members were from at that time, it's a 2-hour drive to get to help here in Little Rock. And then you have an appointment, and then you have to take another 2-hour drive to get back to Phillips County. So basically you've taken the entire day. So you're taking at least half a day off of work, if not the whole day off of work. And that's a big deal. And if you don't have a reliable vehicle, there's not like there's a bus that's taking you from Helena to Little Rock, or a cab or Uber or something like that. They talked again about the stigma, about the inability or the unlikely, you don't want to be seen as needing help. And they talked about, how those stigmatizing beliefs, not only for rural areas, there's a thought about, independence, but for minorities especially, there's this feeling that you should be able to handle this. There's a strong Black woman myth. There's things that, you ought to be able to, your ancestors took care of this, you should be able to take care of this. And so for the ability to say, oh, wait, I need help with something, that was against this resilience they built up as a culture. And they also talked about low mental health literacy. So not really knowing how or when something needs to be taken care of. And so one of the stories in my own family, my mom used to say that, in that day, we didn't have a lot of money, so we didn't go to the doctor unless you were really, really sick. And so she talked about you had to be fever. Something had to be wrong. She's like, we didn't go get dental care, preventative care. You were losing a tooth. That's when we went. And so a lot of times because of that mindset of we go when we actually need help, people are waiting until the symptoms get to a severe enough level to indicate that now it's time to go to get help. And so that understanding of the mild symptoms and understanding of those indicators that may be leading up to that was something that people, especially in rural communities, were not aware of. And so because of these barriers to care, when we look at rural African-American communities, we have a decreased likelihood of seeking treatment, often delays, because remember, they're waiting until those symptoms get severe so they can say, hey, okay, yeah, you really need something to happen right now. Premature termination, that means, it could be because of the transportation, the availability of services, it could be a host of other things, but we know that African-Americans tend to stop treatment prior to receiving the required dose or the recommended dose of care. And we know that quality of care is an issue in rural communities. And so in living in rural areas decreases the likelihood that you'll be able to receive quality care. So what can we do? We can do things like increasing access. And what that means is increasing the reach of an intervention. So we know some information about what works. We know some things about what works well. What we don't know is how do we get people who are in the community connected with those things that we know works well. And when we talk a lot about increasing access to care, we focus a lot on clinics or clinical settings. However, when we're talking about those rural settings, remember those barriers to care, if those clinical settings are not in those areas, increasing access to those clinics may not be the most effective thing. So we started thinking about how do we move our evidence-based care that's within clinics, how do we move that out into the community to make it more easily accessible to our community members? And that starts with understanding those factors that are associated with implementing EBPs in non-clinical setting. So what makes this work? How do we do this? How do we do it in a way that is, we have high levels of fidelity, people are doing it correctly, they're getting the high quality care. And so that's when we took what we know from implementation science, which is how to get people to do things. Jeff Kern always has a way of saying it I can never repeat, but he's like, it's how do you get people to do the thing that you want them to do? So this study is like, how do we promote the adoption of this evidence-based care, the interventions and policies into routine healthcare and public health settings to improve the impact on population health? So we use some of those thoughts about, okay, what can we do to increase these methods to make this work better if we're moving our evidence-based care from clinic to community? But we also know that trust is a big issue when we're talking about dealing with community or talking about mental health care in communities. We wanted to be able to talk about things that were relevant to them. If they feel like the treatment or the intervention or the program didn't have anything to do with them, wasn't created with them in mind, they're more likely to say, I don't want that. And they're more likely to say, you know what, this is not going to be for me, so I'm going to quit early. So we went in wanting to be really mindful of how we engaged our community members and how we work together to co-create interventions that don't just take the scientific knowledge, the things that we know works to decrease symptoms, but it also integrates our community knowledge, because our community members know what are the things that are relevant to them, what are the things that the stressors that they're more likely to experience, what are the things that are going to keep us engaged in this work. So we use our community engagement lens to really be able to bring all of our community stakeholders to the table to sit down together and talk about how can we create programs, interventions, all of that together that are going to be more likely to give people the help that they need when they need it. So that led us to our cultural adaptation. And what we did is we took a actual existing mental health treatment, which behavioral activation, and we worked for months, going down to Phillips County, going down to Jefferson County, sitting down, breaking bread together, eating butter rolls and fried chicken, and talking about how do we make mental health care culturally relevant. And from that, we were able to move into taking bits and pieces of rural African American culture and integrate them with the scientific knowledge. So this was guided by our conceptual model for adaptation. And today I'm going to focus a lot on the analysis and the design development as the things that we kind of lessons learned, so you can see how these things work together. So our first step is the analysis, and that's what it is when you take what do we already know and what's those cultural pieces that we have and how we're going to take that and integrate them with the science. So we found out from our PCORI study that because of low mental health literacy, when people are like, I don't really know when this is a clinical issue or when this is just like, I just stay home and pray about an issue, I don't know what's the difference. So we had to have some education about that. We had to have an educational piece to help people recognize when the depressive symptoms may need a formal treatment. We also had to address the role that social determinants play in the development of depressive symptoms. You know what, I say it all the time, it is hard to be emotionally well when you are broke. It is hard to be emotionally well when you're working multiple jobs, when you have family stressors, and we all know that. And so one of the things with stigma is that it makes you feel like you're the only one or you're all alone. And so we really wanted to understand and put a part of this program that it is normal for us to be, if we're dealing with the things that we're dealing with in the community, that it's going to impact our mental health. And that doesn't mean that you're crazy or something's wrong with you. It means that you're dealing with difficult things, and sometimes dealing with difficult things causes our emotional wellness to take a little bit of a dip. They also talked about the importance of, the social support, making sure you don't feel like you're alone, making sure that you don't feel like you're the only one. So how do we increase that social support? And then how do we provide this within community-based settings? So that's all of the data that we got from the PCORI study. And to the Faith Task Force we go. We took this information, we went back down, had some more fried chicken, and we said, hey, how are we going to do this? So we went to the literature to talk about what are the evidence-based interventions that we know of. And we presented several options to them, and we gave them pros and cons. Here's one that would take this along. This is something that they talk about here. And that's when together we chose the behavioral activation. One, because we knew it had evidence saying that it worked, but it also was a treatment model that was going to be something that we thought could be implemented in low resource areas. So you want to make sure that the intervention that we're coming up with was going to be sustainable. And that's one of the things that one of our pastors talks about all the time is how do we get from the science to actual ministry? And when he says that, he wants to know how can we sustain this within our actual places of worship. And the other reason that we chose behavioral activation is because it had been used before with ethnic minorities. So we knew that it was not just scientifically based, but it worked for other people and it worked for minorities who we were trying to work with here in this project. So then we moved to the design. And this is the piece where it actually gets fun. Not that the other stuff wasn't fun, but this is the fun because you get to design what it's going to look like. And so we knew that if we were going to work with places of worship, we had to incorporate some of the aspects of places of worship or rural African-American churches that were relevant. So it increases the relevance of this intervention. So we started with the addition of scripture. So we talked, there's scripture all throughout the program. This is actual screenshot of one of our pages in the program, and it shows you that the scripture is all the way through. That's something that our Faith Task Force said, if we were going to do Bible study, it would have scriptures. So we made sure that we added those. We actually added a Bible study. So at the end of the sessions, they get a chance to go back and talk about the scriptures that were in the lessons, and they have some discussion questions related to that. So for this particular one, they talked about examples of people who were in the Bible who were greatly distressed and how that worked. And so then they had the opportunity to take that scripture and discuss it more amongst their group. This also, not only is this relevant to the area, so when churches Bible study happens, but it also increases that social support because you're talking together in a group. They wanted us to make sure that we had encouraged some positive coping mechanisms or some positive religious coping things. And so we have worksheets that are in the program that encourage personal prayer time, that encourage, doing activities that make you feel better. So we have those sheets that they can use, that they can take it home, they can copy them, so they can be able to write this down and be able to do that. And again, another piece of the social support part of it is the prayer partner. So we encourage them to have a prayer partner, to think about when you're going to pray together. When are you going to talk on the phone this week? What are we praying about? And so again, they're not alone. They're outside of the group. They're still having someone that they could talk to on a regular basis. And now remember that we talked about the importance of that addressing social determinants to mental health. And so we added in this particular group some things talking about coping with racism and discrimination, dealing with money, understanding trauma and loss. So all of those were these stressors that we had heard about that they said were very, that impacts their mental health. And we talked about what that is. We talked about how some tips to deal with it better. And this was something that allowed them to be able to say, okay, you're right. I understand now that because I had to deal with some things like this, that could be impacting my mental health. So after we get to the analysis, it's time to actually do the development. And so this is the part where we get to put it all together. And so you can see the copy, we have some praise dancers. So those of you who know the praise dancing, with some praise dancers with the sun, but we also have our lessons, our sessions lined out. And so we ended up with 8 sessions. Each session has a overview. It all has a opportunity to talk about, overview of what they talked about the last time, review what they're going to be talking about this time, and then the objectives of the lesson. For our leaders, we give them an actual script that they can follow so they don't have to learn, things or be able to talk about it. I will say almost all of our faith leaders go off script. So the script really for them was just kind of get in their mind what it is that they wanted to say, but they make it their own as they start doing the work. But it was helpful for them, and a lot of them appreciated having something that they can look at and just read verbatim if they needed to. And so I went over this part already, but this is what it ended up being with Rejoice. And we had small groups of 8 to 10 people, and they meet on a weekly basis for 8 weeks. And so for our project, we wanted to have a hybrid 2 implementation trial guided by CBP ARC principles. And all that means is we wanted to ask 3 questions. 1, will Rejoice work to reduce depressive symptoms? 2, how is it best implemented? So how do we do this with churches? How do we partner churches to have this intervention? And can it be sustained? Can we move from just an intervention that's research that UAMS is a part of? Can we move that into ongoing ministry? And so what this looks like is that we have 3 time points. And at time 1, we have people who get the intervention and people who don't get the intervention. So some people are doing Rejoice, some people are not doing Rejoice. And then we test them pre and post. We wait for 4 months, and then we go to time 2. And in time 2, we want to say, what's the best way to make this work in churches? So we asked the churches to do Rejoice again. And those churches that did Rejoice the first time, they do Rejoice again, and they have a coaching call and training. That means someone goes out to them, they train them on how to do it. And every week they get to talk to someone like me about what happened. Let's troubleshoot. Let's give you some support as you're doing it. And so at time 2, we're comparing that against people who just get the training only. And one of the reasons we talked about making that comparison is that, remember, we wanted to do sustainability. And so, if you have an extra coaching call, then that's something that's going to require additional resources. But if we can make sure that our Rejoice leaders have the same level of fidelity to the intervention, even with just training, that means that this is an easier model to sustain. So then at time 2, we were able to test that. And then at time 3, we were like, hey, open to everybody. We just want to see if we don't offer any additional money. So our lay leaders get paid to be a part of the research project. But if we don't do any money, if we don't offer any of that, we just give you materials, is this something that you would keep doing in your church? And so that's the time 3 is, will you offer it again without the incentives that we provide? So now let's talk a little bit about what we learned. What worked really well was our church recruitment. We have our Rejoice team pastors, Pastor Johnny Smith and Pastor Jerome Turner, who have a lot of experience in working in the community. They are known within the religious circles. They're working with our project, and they're the ones that helped us with recruiting churches. So we had 45 churches that we approached about hosting Rejoice, and 40 of those churches consented to join the study. So that's pretty good numbers for getting people to be interested about this. The Rejoice leader recruitment went very well. So the pastors actually, once they say, yes, I want to do this, they look out to their congregation, they say, who can we get to do this? And so they recommended lay leaders. Most of the time when they recommended a lay leader, we were able to get them to sign on. So that part of the recruitment went really well. We had 86 Rejoice leaders approach, 80 of those were trained and consented into the study. So that thought of having pastors reach out to other pastors and then having the pastors reach out to the congregations worked well to get people in because of the trust that our pastors, Turner and Smith, had within the community. Church pastors, local pastors were able to trust them, and then their congregation trusted their pastors. So we all kind of worked together where that piece of the recruitment worked really well. But not everything worked very well. And the piece that we got to where we came up with some stumbling blocks, as our faith task force likes to put it, is when it's time to recruit participants. So our original way of participant recruitment, we had Rejoice leaders and our study staff held orientations. So just a kind of information session at the church about Rejoice, what it was, and we asked them to consent to be screened. And the participants who had mild levels of depressive symptoms, they were eligible for the study. Because again, this was a study where we're trying to do more of a preventative lens versus just a treatment lens. And so we had 250 people who said they were interested, but only 11% of those were eligible for the study. And so this resulted in slow participant recruitment. And if you've ever been a part of a program or a group where you get people really excited to do something and then they have to wait until they get a chance to do it, you start losing your Rejoice leaders, and it's hard to be able to engage them. So we started getting a lot of feedback on this part of the study. And so one of the things, one of our Rejoice leaders, and one of the things I remember the most was that she's like, I just got a call from one of the people that I recruited. And she said, these people asking me all these questions, they think I'm crazy. I ain't telling them nothing about me. And we looked at some of our PHQ-9 studies and look at the results. And we found that people were like at the 1 or 2. They were only endorsing like 1s or 2s. And I was like, wow, I'm not clinically depressed on these measures, but I'm higher than the 2. Like they are really don't have any depressive symptoms. And when we got this call, we were, I wonder if people really are underreporting because they don't want to be seen as crazy. Then our pastor talked about, in the African American community, resilience is important. And so one of the things that is talked about in churches is that churches are a place of hope. In the midst of oppression, you can keep your hope. So there's lots of sermons, there's songs, there's, prayers about having hope, even though you're oppressed. And so our pastor said, I think that sometimes when we ask the question on the PHQ-9, where we say, have you been more tired or something than normal? How many days of the week? He said, if somebody's been tired for 5 or 6 years or 10 years or 20 years, that tiredness seems normal. That stress seems normal. And he said, so it's hard for me to say this is not normal. But it's also hard for me to then say this thing that I've been using for resilience, this thing that I've been using to cope with, that now I'm saying, oh, it's not working. I need to use something else. So there was a church culture piece that we didn't include in our original adaptation that we maybe were coming against. And another church culture piece that we didn't quite have in our intervention was this thought that everybody can come. So when you go to churches, and there's been health promotion issues in churches, programs in churches for a long time, about weight loss, about cancer, things of that nature. And so usually it's open to everyone. If you want to come, you can come. We're not going to ask you any questions. But because this was a research study, we were doing more screening at the front end, and not everybody could come. And so then that was also causing issues, because if we had 2 friends go and one friend got in and one friend didn't, then they were talking to each other. Well, why'd you get in and why didn't you get in? And so it was against this church culture where when they usually provide a resource, everyone at the church was eligible to come. And so that was one of the things that we had to keep in mind, and we had to go back to the table and think about. So we went back to the table, this time not quite with fried chicken, but with a lot of discussion. And we talked about a couple of questions. And it said, one of our pastors, he calls himself a trailblazer. He's like, we are trailblazers in this. In the rural communities of Arkansas, we did not have conversations about mental health in churches. Didn't really happen. And so we talked about, what if we aren't ready to go from absolutely no discussion of emotional wellness to a full-fledged intervention? And we talked to some of our pastors, and they said, we haven't talked about much about emotional wellness. We know it's important, we just haven't focused on it. And for me, I just have to get used to starting that conversation. And so our community talked about, what can we do? And they said, our orientations that just kind of tell you, here's the program and what it does, may need an extra piece. So we incorporated some depression education and testimonies in that orientation. So we had some people from our community talk about how they dealt with depression. And sometimes they talked about they were depressed for a while and didn't know that they were depressed until much later. They looked back and said, what? I never left my room. I went from work to my room. I stayed in this one area. I wonder if that could be depression. And we had another one said, well, my friends told me you might be depressed. And I said, they didn't know what they were talking about. And now I look back on it, I see what they saw. And I said, I wish I would have been able to get some help during that time. Maybe it wouldn't have been as difficult. So they told their stories, they gave testimonies. And again, in rural African-American churches, testimonies are part of the faith culture, where you're providing some information about how you've been brought over or how you handled something difficult. The second question was about our research design. And it was like, what is it if we have a research that is designed that's really great? All the scientists are like, yay, this is a great design. This is going to really tell us that, but it's a mismatch with the church culture. And our leaders kept saying, if we could just take that depression criteria out. If we could just let everybody come if they wanted to come and just sit down and talk with us if they wanted to talk, we would increase the amount of people we were working with. And our pastor, we teach hope. And when we ask people to come in and say, what's wrong with you? And if we're talking about hope, and some of the messages that we hear in churches, such as I'm too blessed to be stressed, that goes against what they're hearing from the pulpit. So maybe this research design is not quite matched up with what we have in our culture. So we had to change our project scope. So we focus less on the effectiveness of rejoicing, decreasing depressive symptoms, and more on the impact of building emotional wellness and things like increasing self-esteem, increasing healthy coping, things of that nature, because that fits more with the church culture than focusing on that medical model that talks about decreasing of symptoms. And so this was something we had to work with our funder about, because funders are focused on the clinical effectiveness. What is the outcome? And to go back and talk to them about focusing on these things that may impact clinical outcomes, but not necessarily look at the clinical outcome yet, may be a first step in getting studies into this type of setting. So we talked about these lessons learned, and I could talk about how researchers use them and how we use them for our study, but I did want to just take a little bit of a turn to talk about what clinicians can learn from this study and what are lessons that we learned. We learned about building relationships, and it was the key thing that helps us be able to continue this work. Our pastors that work with us are like, hey, if they don't trust us, then they're not going to talk about this. And it's different because we really need that trust, especially for issues that are not easily talked about or that we haven't talked about a lot. So doing a weight loss intervention in the church may not need as much of the trust factor, but when we're talking about things like depression or mental health, emotional wellness, it does. And we see it again now that we're talking about vaccines and vaccine hesitancy. Trust means a lot. And so we've learned about building relationships. And I know that probably all of you who are full-time clinicians on this call are like, girl, don't give us one more thing to do. In this time of COVID, we are at capacity, we're done. But just in case you have like a little bit of capacity, there are some things that have been really helpful in moving this work along. And it's actually meeting with the faith leaders and providing education to faith leaders about mental health. And so we have the Arkansas Faith Network has a speakers bureau, and you can go to arfaithnetwork.org and sign up for that, or you can contact Kenesha Bryant Moore. Her email address is kjbryant@uams.edu. And you can be a part of the Speakers Bureau. We have seen a huge increase in the number of places of worship during COVID-19 that want to have someone come out and talk about mental health. So this project was funded about 5 years ago. We were not getting people who wanted to come in and talk about, they did not call us to come talk about mental health. They called us to talk about a lot of other stuff, but not about mental health as much. We're getting lots of calls. So building those relationships, Arkansas Faith Network has already started building some of those relationships. So you don't have to do that part. But if you want to be more a part of talking about mental health, joining that Speakers Bureau so that when we have those requests come in, we can reach out to you and ask you to be a part of that would be super good. We also about providing resources, and we do educational talks, we do lunch and learns about mental health, we give out brochures about mental health, and sometimes it'd be great to hear from our clinicians about what are some of the things that we need to be talking about with faith communities. So what are you seeing right now that we need to be providing education about? Do you have some brochures, you have some reading literature and things like that would be great for us to pass out to our faith leaders that we already have. This is easy way for you to just kind of shoot us an email and say, you know what, anxiety is huge. Here's a great resource I've been giving my patients that I think that everyone can use, that they could just put in their little bulletins at church. They could put it on the, on the Facebook page and all those kind of things. Those are great information for you to pass along to us, for us to be able to say, okay, we can do that. And we talk about promoting resilience. And so the Faith Network has a resilient toolkit. This toolkit is just about tips and strategies of how you can build resilience within faith communities. And so we have that available, and we encourage clinicians that when you go to Arkansas Faith Network and sign up for the listserv, when that comes out, have that, something that you could have available in your in your practice, on your computer, and your phone that you can pull up and maybe have for your patients. But if I happen to be talking to a faith leader, if you're a part of a place of worship, passing those resources along so that people know about that. And then also we're doing work to promote the positive coping skills. And so we encourage our clinicians on the call to help us promote positive coping skills. Our previous speaker talked about her blog and her podcast and all of that. If you have social media presence and all of that, please talk about promoting positive coping, because that is something that we're seeing a lot of requests for, and things like, how do I do self-care? That's a new buzzword right now. So everybody's like, how do I do self-care, and what should I be doing, and what should I be thinking about? And so we actually have self-care boxes that we're going to be giving out to the first 200 people that come. And I just want to show this. It has probably not a whole lot to do with what I'm talking about, but we have a sleep mask that says sleep is holy. It is my favorite thing ever. So we have things like that talk about getting good sleep. We have a mug that says self-care is for everyone, and some tea. We have things like that people can use, and actual concrete techniques and strategies that they can have to put their hands on and say, this is what I need to be doing to increase my positive coping. So if you can spread words about things that we're already doing, that's really great. If you say, I don't have time to go out and have a meeting with all the faith leaders in my neighborhood and talk to them about that. These are some easier ways that you can kind of just connect with what we're doing and get that word out. But again, if you want to build those relationships, we just want to make sure that we provide some things, some tips. The one is the face-to-face fellowship is important. I know in the time of COVID, we're not really doing a whole lot of that. So actually, virtual is kind of working right now, but people still want that face-to-face contact. Making sure that the partnerships are mutually beneficial. Making sure that you listen to what it is that they need. And a lot of times there's a quote that says people they don't care how much you know until they know how much you care. That's the quote. And so those partnerships start off with you showing how much you care about them, that you want to be helpful. And so when you're having those conversations and listening to needs and making sure that they're getting things from it and that you're getting what you need from it as well, is going to be the best way. And then making sure that you feel comfortable. You can also talk to us at the Faith Network if you've not had a conversation with faith leaders before and you're like, hey, I don't want to do that. You can bring in some of us who've been doing this for quite some time, and we're happy to help and build that comfortability for you, that comfort for you. I also just want to make sure that you guys are aware of a couple of resources, because we're always talking, when we're talking to faith leaders, there's always a question about how do I link my congregation to services. So there are some, if you can link to other local mental health providers, there are some directories. I know Kyla has worked on a directory Dr. Holmes has worked on a directory that's been put together. But having directory of services that you can give to faith leaders is really, really important. They really, really, really want that. There are also some local providers like the State Department of Health. I don't know if you know this, but the State Department of Health has a faith-based health promotion office. And the director of that office is Kimberly Heyman. And if you wanted to get more information about what can we do with faith leaders, she can also put you on a list if she needs speakers about mental health. If you have other things like, I really think that this is an important thing to get out to our faith community in Arkansas, she can help with that. Her information is on the screen. And then if you're not affiliated with NAMI, NAMI Arkansas also does quite a bit of outreach to faith communities. And so they're another resource for information and brochures, but also you could talk to them and partner with them about what are some of the information that we want to get out to faith leaders. So those are just a few things that you can put in your clinician hat. I know you're busy right now. Every clinician that I know is like, we are completely at capacity and burnout. So my heart and all of my positive thoughts for all of you who are providing care right now, and my thanks to all of you who are providing care right now. And so don't think of this as an extra thing to do. Just put this away. And if the opportunity arises that you need to partner with faith communities, you have this that you can go back to and pull out and say, hey, here are some ways that we could do this. But now to the end of the research piece. So clinician hat off, research hat back on to finish up. Disparities in mental health, they exist right now. And we need to think about how do we increase the reach of what we know works, and how do we get it to the people who need it the most? So how do we get that evidence-based care into non-clinical settings? And so that makes us focus on what are those things that we need to do in order to be able to implement these services effectively. And we need to understand how we can work with our community to be able to do this well. So continuous engagement. If we had just only talked to our community engagement or our community advisory boards and faith task force at the beginning, we would have missed how we can make sure that this matches church culture now. So we have to continue to talk to them over and over again. We meet with them monthly. Sometimes if we have something going on, I'll call them on the phone, I'll text them because they don't like the email. So we text all the time, we talk about these things. And so you have to build that relationship with your community advisors so that they're able to give you that information. And one of our pastors said the other day, he said, he said, we have such a trusting relationship between us, the academics and the churches and our Rejoice leaders, that we feel comfortable enough to come and tell you this isn't working. And you feel comfortable enough with us to understand that when we're saying it isn't working, to trust us to come up with a solution. And that's that level of trust and community engagement that's important if we're going to actually address the disparities in mental health care. So at the end of the day, we have a project that's very different from what we originally envisioned, but ultimately has the potential to impact more people. And at the end of the day, that's really what we want to do. So that's the end of what I have. I see there's some questions in the chat. So let me look. And Dr. Holmes, please chime in if I missed some. Okay, are there certain churches or church characteristics in which Rejoice was more likely to be effective and sustained? Yes. So there were churches who had a larger membership, so 100 members or more. Those were more likely to sustain Rejoice. We realized too that we had quite a few of our Rejoice leaders who, when the pastor suggested them, he was suggesting people that were already very busy. So we're getting people who are like, I'm already teaching Sunday school, I'm already teaching, Bible study. I do vacation Bible school, I sing in the choir, and I'm adding this. They were more likely to kind of be able to drop out because they had too much on their plate. So being able to talk to them about expectations up front and talk about how much time this would take really helped us be able to sustain. So faith leaders who had Rejoice leaders who were more balanced in the ministries they had on in the church were more likely to stay in the study. And then we know that churches who had done health promotion before were more likely to complete the study. So those were the churches who had done weight loss interventions or healthy eating and things like that. They kind of had this culture already built. And so they were more likely to be a part of that study. And when we talk to our Time 3 churches about sustainability, we have some of that just initial data. We haven't analyzed it all, but when we're talking to them, they all say that they'd be really interested in keeping Rejoice as a part of their ministry if they can make it a part of an existing ministry like their Bible study. So rather than having an extra class, they were more interested in having for this 8 weeks, our Bible study is going to be about emotional wellness. And so we're going to follow this curriculum. So they were able to tell us, so churches who already had existing ministries that they could see this going into were more likely to talk about wanting to do it again later on and keeping this an ongoing part of their ministry. Did that answer you, Dr. Holmes?
Yes, that's it, Dr. Haynes. And it wasn't any other questions before that. So we just have a question. The next question is by Dr. Griffin. Okay.
Do you offer any cultural training for those who want to participate, however may not think they have the skill set for work? Oh, not formally, but informally, we do talk to people who are interested in working with the community, especially if you want to do like talks or things of that nature. And you're like, I don't really do community talks. We will offer you the opportunity to talk with us first to kind of practice. And then we'll tell you the things like lay language and community friendly language that we try to add in. So a lot of times when we're clinicians or academics, we use that language all the time. We just start talking, and then our lay people, they just smiling and nodding at us, but they're not really, because they don't want to stop us and ask what it is. So we do talk about that a little bit. Anything more intense than that, we'd have to talk a little bit more about. Okay, since so many providers are not taking new patients, that is right. I get so many requests for people to connect people to services, and all my go-to people are like, I'm full. So I'm very sad. Okay, do you think that we need more? I think so. I think that what we've seen in COVID now is this ability to say, you know what, I am experiencing something going on, or there's some symptoms that are going on right now that I think I need help with. And if we can start talking about more in a prevention manner, and we think of this kind of like if there's some things that we can start people doing earlier that will keep symptoms from being more severe or more or delaying that treatment, that we can do that stuff now. And I think that this is presenting us a venue now for us to be able to talk about this more freely. I don't know, I'm sure all of you have seen the discussions about mental health have been all over social media, everywhere. We have a lot of athletes talking about it. A lot of leaders are talking about it. I think we have a unique area in time where we can start talking more about mental health. And this is the best time to start getting things like this program in community settings so that we're more able and better able to serve the community, especially when we have our mental health providers who may be providing specialty treatment that only you can provide. If you're full, if there's some other ways that we can help people who may not quite be at that level yet, but still need some help, then this is a good area or time for us to do that. Okay. And Betty is just like the most amazing cheerleader ever. Okay. Okay. Do you think this could be adapted for a more medical setting to work with patients who might benefit from, oh, probably. I think that it, you know, the way that it's set up, it could definitely be adapted that way. And we should talk about it, Tisha. I mean, and see what we can do with doing it in primary care. We haven't talked about it being that way, but I'm sure we can make it happen. All right, I think that's all my questions.
Hey, well, Dr. Haynes, I actually, okay, for sure. Good. Tisha's just responding there. People are saying excellent presentation. Dr. Haynes, are there some next steps with this that you feel like for Rejoice, for the Faith Network? What are some next steps?
So our biggest next step is working with pastors. We had a lot of our pastors, particularly in COVID, talk to us about how stressful it's been for them. Some of our pastors in between like April 2020 and November 2020, almost tripled the amount of funerals that they were involved in. They had to take on, you know, doing food drop-offs. They had to very quickly pivot and learn how to do online ministry. Several of our pastors in rural areas had no online platform at all. So some of the larger churches had, you know, were doing services on Facebook. They were not. So they had to learn very quickly how to pivot, how to become that. And so really they are what we would think of as first responders in the time of public health crisis in these communities. They are the ones who people are going to, they're talking to them. They are coming up with, you know, they're doing the work out here in the first responders, and there wasn't anything for them to help them deal with the stress and the increase in depressive symptoms and stuff that they were experiencing. And they didn't really have a safe space to talk about that because they were, expected to be the ones that had it going on. And so we have spent some time talking to pastors about what do they need to help their emotional wellness as they are being first responders, not just for COVID-19, but we see it all the time when there's a flood, when there's a tornado, when there's a death in the community, pastors show up and they're the ones that are providing comfort. And so how do we help them? And so the next step is that we are adapting kind of what we did for Rejoice to be useful for our pastors. So talking to them about, you know, how you can lead and take care of yourself, how you're balancing leading and helping others and also taking care of yourself, how you're balancing this new move to ministry and stuff like that. We, you know, we're talking to them about that. We're talking to them about sleep, you know, just like the basic self-care things, like you cannot keep pouring out of this empty bucket. How we make sure that you're getting enough sleep, that you're eating well. And then also I see someone in the chat, Dr. Griffin talked about a clergy support group. And that's kind of it's the same thing that we do at Rejoice, is you build this kind of support group where you can talk to people about what's going on and different ideas and how do you keep this going on. And we're also asking them about the actual practical pieces of ministry and during this time. So how do you keep your church going when no one's inside the churches, or when you have when you're all online, and especially with rural churches that donations may have dropped because you didn't have your online giving set up. And so you're dealing with the financial pieces of that. So we're asking, you know, getting the practical pieces that are going on with that as well. So that's really the next step for Rejoice. And I think Faith Network is going to kind of take that on to be a part of it as well.
That sounds excellent. Excellent. Thank you so much, Dr. Haynes. You provided some excellent information to us. People are saying great work, great work. Thank you. Amy says she wants you to go to PEDS after that. So after you get it figured out with Tisha and primary care, if you can move it on over to PEDS, the PEDS population. So it just seems like it's needed in several different settings. And this is great work that you're doing. Thank you for presenting this to our group. We appreciate it. Wonderful talent going on here in the state of Arkansas. So as you all can see in the chat, Eric has put the link to the evaluation. So if you could please pay attention to that. So and this is the conclusion of our conference. So thank you again, Dr. Haynes and Dr. Rutherford, for just letting us know what we have going on in the state of Arkansas. We have a lot of talented people doing a lot of great work that's very much needed. So as we close out, again, thank you for everybody for attending. Feel free for people that are on. This is kind of impromptu type of thing, but if you are still on and you're willing to turn your camera on, feel free to do that just as a way for us to see each other. Yeah, Tisha,